Right.
All
Thank you
right.
so much. And we move on to our next talk, and that is the last of this session by Dr. Fairooz, and that will be on retinoblastoma, the newer trends, and we would like to hear from your global perspectives as well.
All right. Thank you so much for having me here. It has been on orbit. It's a little deviation from the overall subject. And I think retinoblastoma is important for many reasons for us as practicing ocular oncologist. I'm extremely grateful to my entire team. Retinoblastoma is just not me or an ocular oncologist. It takes a village to treat a child, including all the specialists. And this is my gang, and also the foundations which really helps me to deal with these, financially poor patients, and none of the patients should go away without the treatment. And in India, we definitely have that spiritual DNA with all these foundations helping these children. So I would just want to highlight here regarding the current trends, how changed, retinoblastoma management has evolved from the past. And this is the picture here from the 19th century to the 21st century, where a father of the child, genetic germline retinoblastoma, has lost both eyes enucleated, radiated. All right, and when this child presented in 21st century, we could salvage one eye, and even if the other eye was enucleated, there is a quality of life and a cosmesis where a child could actually lead a good life. So now the trend of retinoblastoma is just not fighting the cancer for survival. It's about sight. Most importantly, we have actually successfully gone and tread that path, smiles and second chances in life for these patients. Just an introduction, we all know that most common childhood intraocular malignancy is retinoblastoma. And in India, why is it so important for us is that we see the maximum number of cases, which is reported to be 8,000 to 9,000 cases per year, which is as high as 2,000. And in fact, the incidence of retinoblastoma has increased in the recent past. Whereas in United States, they see only 200 to 300 cases per year. So this is the burden of retinoblastoma that we have here, and 90% of these cases come from low and middle income countries all over the world, including us. So what is trending in retinoblastoma? Nutshell, eye and vision salvage has become really important, and we are trending in that way. Customized patient-centered treatment approach. Not one patient fits, not one protocol fits in for all patients. So we have learned to customize the treatment. Tumor targeted therapies, well, we have so much to set forward in future for molecular therapies. We are still not there, but yes, the research is going on, like genetic advances and gene therapies, diagnostics and AI technology. AI technology has been embraced by few of the institutes for teleophthalmology, especially during the COVID. This has become as a trend in retinoblastoma, so that none of the patient is missed in diagnosis, and of course improving the quality of life. Now the trend in India has been changing. We are seeing more patients now. For example, in late 19th century, the infant mortality rate was much higher in India, but now the infant mortality rate has improved. So there are so many infants living, and there is early diagnosis, and we are seeing more of patients, and that is the change in the trend. Stories are always important so that you learn from it. So this is a child in August 2018 that I saw, bilateral retinoblastoma in a 9-year-old child, where it's an anterior segment retinoblastoma, done chemotherapy elsewhere, planning for bilateral enucleation. As you can see here, the left eye is already thicical and the other eye has anterior segment seeds. Now, what to do next? So his posterior fundus is well taken care, tumor regressed, but what you can see here is anterior segment seeding. In fact, it was diffuse, but what you can see here is in the 12 o'clock position, ciliary body seeding all around the inferior portion. Now, what do you do? I mean, do you really enucleate that eye where the posterior chamber is absolutely clear and there is a potential for vision? Thanks to the advancement. So we have intravitreal topotecan with us. We also do intracameral topotecan, where locally these tumors are taken care, and there is an effort from us to somehow save that eye. And this child received 8 intravitreal topotecan injection, intracameral topotecan injection, focal peripheral cryotherapy to take care of the ciliary body seeds, and of course left eye was thicical, it was enucleated. Well, a ruthenium plug brachytherapy was also added. So it's basically a multimodal treatment protocol that we follow in retinoblastoma. It's just not systemic chemotherapy and other focal therapies. Of course, He landed up with a cataract because of the extensive treatment and the plaque brachytherapy, and a cataract surgery was done for him. So there is again a team of people trying to, save the vision, and we are trying. We are in a position where actually we have good outcomes in these bad cases as well. So his best corrected visual acuity after all these treatment in June 2025, touch wood, without recurrence, has been 6 by 24, and one eye has been salvaged. And thanks to all the research and this newer advancement in the treatment. Similar cases, post-treatment chemotherapy, intravitreal injection, laser therapy, the eye has been saved. Systemic chemotherapy, periocular topotecan, intravitreal topotecan, in a very bad case where only one eye could be salvaged, we have much more vision salvage in these children. Next is intra-arterial chemotherapy, where, large tumors in children where we know that group E eyes usually go for enucleation, but there are certain group E eyes also, apart from group D eyes, that can be salvaged with intra-arterial chemotherapy. A large tumor here, as you can see here, with combination with intravitreal topotecan, the eye has been salvaged. Plaque brachytherapy as well, we have the Indian made ruthenium plaque available now. So even small recurrences where has been very resistant to chemotherapy as chemoresistant tumors, plaque brachytherapy, which is very focal and localized with ruthenium plaques, we have been able to salvage many eyes. So the eye preservation treatment strategies in retinoblastoma in 7 minutes, this is how I would like to conclude: systemic chemotherapy, intraarterial and intraocular chemotherapy with all the adjuvant others. Now, life salvage in treatment strategies in retinoblastoma, yes, this is the intensive multimodal treatment protocol. I think Dr. Honavar has gifted this to the low-income countries where we see a lot of orbital retinoblastoma with this treatment protocol, with safe VEC protocol, which is escalated dose followed by enucleation, external beam radiotherapy, and high-dose chemotherapy as an adjuvant chemo, and we have been able to save many lives as well. So conventionally with exentration, which no more do in orbital retinoblastoma, no exentration in orbital retinoblastoma, even with an addition of chemotherapy and radiotherapy alone, the survival rate was only 44% in the past, but with this multimodal treatment protocol, we have reached to 90%. Now, enucleation is not the end of treatment. Histopathological evaluation detailed has to be done to identify the pathological risk features. And this is a child who has undergone enucleation. Which eye? Left eye, yes. But still, the cosmos is amazing, and that is the quality of life that we want to actually promise the parents. Genetic advances in retinoblastoma, in a nutshell, we all know that it's a genetic disease, and there has been various pathways which has been identified at this point of time. There are liquid biopsies which we do and identify, the cDNA, ctDNA in retinoblastoma in order to know the prognosis, as well as various other molecular targeted therapies. Everything is under experiment, unlike uveal melanoma, which is taken, way ahead. Probably in future, we will come across the nanoparticle delivery therapies or gene therapies or the MABs, which will be really helpful in retinoblastoma. So concluding in the 7 minutes, retinoblastoma future trends would be precise, patient-centered, holistic approach, because these are kids and these are our future. So from life, vision and eye, life, eye and vision salvage, what we are trying maximum is vision, eye, and of course, we have crafted the life salvage already. Thank you so very much for your patient listening.
Thank you so much. I do have a question, and we'll be open to the audience then. For the case with the ciliary body seeding, which quadrant was the seeding exactly?
Ciliary body seeding, diffuse seeding.
It was diffuse.
Diffuse, yeah. Every quadrant. You saw the 12 o'clock anterior segment. So if you have an anterior segment seeding, obviously the ciliary body is involved. So it was all around.
All
diffuse,
around.
yeah.
Then which quadrant did you pick for intravitreal and for intracameral?
Intracameral, it doesn't really matter because it's a clear corneal thing that we are going inside. Intravitreal, when we see clinically, usually the rule is 3 clock hours away from it, but there are papers where they have even injected over the seeds and
Okay.
shields one of the papers. So actually, it really doesn't matter much. It's just that taking care of the seeds. But stick to, as a beginner, it will be really nice to stick 3 clock hours away from the seeds. Wherever there is a dense seed, it's avoided. It's better to avoid injecting there. And intracameral, it really doesn't matter because you're going clear corneal.
Right. And on approximately how many injections did you see the great resolution that you showed?
As you saw, I gave him 8
8.
injection intravitreal and 3 intracameral injection.
Right.
The numbers were there on the slides.
Thank you so much.
Yeah.
Thank you. Any questions from the audience?
Intravitreal. Yeah. So if it's a very severe disease, I give 2 weekly injection. But if it's not not this case, any case, if there is vitreoseeds which is not too severe, 4 weekly EUAs when I do, or 3 weekly EUAs when I do, I give injection. And if it's an outstation patient, I definitely stick on to 2 weeks because I somehow want to control it. Yeah.
Right.
Thank you.
Yes, Dr. Shah.
Yeah, a good question actually. So what I do is I start with focal therapies of intravitreal and intracameral, but there are ciliary body which is a little bit more infiltrative and bigger, which doesn't go away. So that area after the local therapies, finally I decide plaque brachytherapy, and it's a plaque kept on the ciliary body. We always give a margin of 2 millimeters to 4 millimeters in and around. So in that patient, most of the seeds were concentrated in the inferior portion. It was from 5 clock hours to 7 clock hours. So that's exactly where I kept the plaque. Rest of the seedings were diffuse, but it was manageable and controlled by, I even gave cryotherapy to few focal ciliary body areas. So this patient received it in the inferior area, over the ciliary body. It's very straightforward. It's like keeping it over the surface, yeah. Yes, it is. It is an option. Yes. Right. Yeah. Yeah. But then, yeah, yes, it's about cataract and stuff. And as you saw, cataract surgery is not difficult in these cases. Well, yeah, they might land up with cataract. Yeah.
Thank you so much.
Pleasure.
I
Thank
thank
you.
the speakers and the audience for this wonderful session.